Thank you and good morning, colleagues. This talk is about new bone-seeking bisphosphonates for both diagnosis, but mainly, of course, therapy. And before I explain our approach to the new design of these tracers, I would like to refer to the traditional way bone-seeking compounds are synthesized and are in the clinic. And this is true for technetium and also for rhenium, that the key moiety is a bisphosphonate, but the preparation of the pharmaceutical includes coordination of the radiometal to the bisphosphonates. So the bisphosphonates are not freely available for binding to the bone metastasis because they are in part needed to coordinate the radiometal. And the same is true for the trivalent radiometals. For samarium, for example, in the EDTMP compound or in the macrocyclic version of a phosphonate bone-seeking tracers, they all need the phosphonate moiety to coordinate the central cation. So I try to illustrate that concept saying that this is the target, the bone metastasis, this is a radiometal. And the chelate is containing both the coordination chemistry, which is here in yellow, and the targeting property of the chelate. So this is mixed. And we may speculate that none of these two functions is 100% perfect. But this is the reason we came up with a new design for these bisphosphonate-based bone-seeking compounds, which is to disconnect the two functionalities of the tracers. What I'm saying is, let us free the bisphosphonate, which then is 100% available for binding to the bone metastasis. And this requires the introduction of a dedicated chelate to coordinate the radiometal. Actually, this is not new at all these years, because this is the general design of the octreotides or the PSMA conjugated tracers to disconnect the binding of the radiometal and the biological targeting moiety. Well, these are then typical examples. This is a hydroxy bisphosphonate covalently attached to the chelate. It's a DOTA here. And then we have the two moieties separated. We have started with the what we call first generations of that new design, and I show you some of the compounds, and I will go a little bit through the highlighted ones here in terms of gallium labeling. One is the NOTA analog of a bisphosphonate, and the other one is a DOTA analog. I completely skipped the chemistry because there's no time for the chemistry, and just showed how the compounds perform. This is a comparison of the NOTA conjugated bisphosphonate gallium-68 labeled PET imaging here compared to the F18 PET bone imaging agent. This was done in collaboration with a group in Ames in New Delhi. And there's a one-to-one correlation between the SUVs of the two different tracers for one and the same metastasis. This is expressed in SUV values, and though the performance of the NOTA analog is as good as F18 PET imaging of bone metastasis. And then we went to the DOTA instead of the NOTA because, as I mentioned in the beginning, it was not our aim to develop just another diagnostic bone tracer. Our intention is indeed to develop a theranostic platform to treat the metastasis, and DOTA was then the candidate because it's also able to coordinate lutetium or other trivalent therapeutic isotopes. And this was the first study we did with Richard Baum and Bart Berger already a few years ago, and shows that the DOTA gallium bisphosphonate works very pretty. This encouraged us to do similar studies now with the lutetium-labeled analog of this compound in the real theranostic concept. And this is the image of a patient at different time points shortly after injection, 3 hours, and the other day. And you see that as we expect, there's a exclusive accumulation of the activity on the bone structure, and all the other organs are completely free of any activity. Richard Baum gave me, and unfortunately he was not able to describe it personally, this slide for one of his patients, professor of literature, with this history of his disease, and the point was that he developed very painful bone metastasis here and was unable to sit, and in his profession it was really a disaster. So Richard decided to treat him with 4 cycles of the lutetium BPAMD, and this is the individual cycles. And finally, Richard told me that the osteometabolic activity was significantly reduced, and the patient was free of pain and could work. Well, this was our first generation of the new design, but then we decided to optimize the bisphosphonate moiety of that concept. This was the one I was talking about. This was this very, very simple bisphosphonate, the same as similar to the MTP and the technetium tracers, but it is known from the conventional drug development to treat bone diseases that a hydroxy group in the bisphosphonate structure increases the binding to the hydroxyapatite structures. And then it's even more pronounced if, in addition to the hydroxy functions, there are nitrogen-containing heterocyclic moieties. And the best compound now in clinical routine in the conventional treatment of bone disease is soletronate. And we decided to adapt this moiety and couple this part of the molecule to the DOTA chelate. Again, I skipped the chemistry, just show the different generations we now are talking about, the simple bisphosphonate, a hydroxy version, and the nitrogen-containing molecule. We call it DOTA soletronate. And here is the organ distribution of the different compounds in healthy red, and we always take out the femur, and you see that the uptake of the gallium-labeled compound on the femur almost doubles compared to our first generation compound to the new soletronate version. So these images I showed you before already were very, very promising, but now we double the uptake of the compound on the healthy bone surface. At the same time, the tracer clears rapidly from the blood, and the concentration of the tracer in the blood pool 1 hour after injection is already half of that of the BPAMT we studied earlier. We did the same now with the lutetium version of that soletronate. These are SPECT images, and this was done in collaboration with my friend Ralf Bergmann in Dresden. And again, this is an exclusive uptake of the compound on the skeleton. And it's interesting to note that almost half the activity is taken up by the bone an hour after injection and remains there, let's say, forever. Yeah. With our nuclear medicine physician partners in Berlin, they did SPECT imaging. I just go through these images. These are just images. This is from Mike Sateke in South Africa, and this brilliant imaging of the disease in prostate cancer patients. He was the first also to inject a therapeutic dose of the soletronate following the gallium PET imaging. He decided to inject 7 gigabecquerel of the lutetium DOTA compound in a prostate cancer, and it is just a bisphosphonate, but you see that it is working also in terms of the treatment of the disease, pancreatic cancer, by reducing the PSA level of the patient. So what we are doing now is we are really interested in quantify the radiation dose of our compound, the lutetium dotatate, and we need to compare it with, of course, the Xofigo and with also the PSMA. And there are 3 preliminary studies. One is, again, by Richard Baum, who in 18 patients determined the radiation mean absorbed dose to the whole body and kidney of the patients and to the skeletal metastasis. And his message here is, and this is for the BPAMD, that the mean dose per treatment is about 100 Gray. And remember, this is a BPAMD, our first generation compound, and now we are doing similar studies with soletronate, which was twice as effective in the healthy rat model. So we expect here with soletronate significant numbers of the radiation dose delivered to a skeletal metastasis, and we know from the blood clearance that this is even then lower. Our colleagues in Essen, they do these studies right now, and this is again showing that there is fast clearance from all the whole healthy organs in the body. This is kidney elimination within half an hour, and this is the uptake of the lutetium, the therapeutic tracer, 19 hours post-injection, and there's no retention in any healthy part of the patient's body. Well, so there's our recent data from the study in Bonn. They determined the preliminary data for kidney and red bone marrow dose, and they still need to calculate the dose to this metastasis, compare that to the PPMD, but we are quite optimistic that we approach 200 Gray per injection. Another interesting point was also done by our colleagues in Berlin. This is a nuclear medicine private practice, and they were interested whether they can do this treatment in-house. So they investigated 10 patients with, we call it a diagnostic dose of the lutetium dotatate, with the vision to extrapolate what will be the radiation dose this patient delivers to his family after leaving the hospital the same day. And indeed, they figured out that the overall dose delivered to the family members is in that range, and this is exactly according to the outpatient strategy of these compounds. Well, this is all promising, and of course we need to compare, we don't need, but we may compare the performance of our bisphosphonate tracers with PSMA, because it's also a tracer accumulating in bone metastasis for prostate cancer patients. And Mike Sateke did a first patient, and he is now doing a group of patients with a one-to-one comparison of the uptake of the gallium-labeled PSMA compound and its soletronate. And they quantify the SUV in the many bone metastasis, and this here is the ratio between the uptake of the bisphosphonate and the PSMA. And you see always that the bisphosphonate uptake is much higher than that of the PSMA tracer by factors of 2, 3, 4, 5, up to 10. And the same is true, but in the other direction for the SUV values in healthy organs, in the glands, the liver, kidneys, and so on. This is less by a factor of 2 to 5 for the bisphosphonate. Again, underlining that these bisphosphonates are extremely specific for bone disease. The other compound to compare, and this is our main target, is the Xofigo. We did a comparison in the healthy rat model, showing that the uptake of our bisphosphonates, and this is even not the best one here included, is similar to that of the radium. This is okay. With the soletronate, we are improving that, but the main problem is the accumulation of the radium in healthy tissue. Of course, radium is a calcium mimetic, and it is accumulated everywhere in the body where calcium plays a role. And this is, in fact, another advantage of our lutetium bisphosphonates. The ratio between the uptake of the bone to intestine, for example, is incredibly in advantage for our bisphosphonates compared to the alpha radine. And these are images the company now is not showing anymore, but these are earlier images with the radium injected into a patient and showing the significant uptake in the non-target organs. And this is a reason, of course, that the activity needed for patient treatment with radium is very low. Well, in my conclusion is now with this new design of bisphosphonate tracers, which is exactly the state-of-the-art design of the other gallium and lutetium tracers. We really free the bisphosphonate moiety, and we see a higher uptake of these compounds on bone surface. We still now modify the bisphosphonate moiety. We optimize the chelate and tune the chelate according to the coordination chemistry of the diagnostic metals, gallium, scandium, as we heard yesterday, and lutetium-177. And for the moment, the soletromate is our lead compound. Last week, we already compared the uptake of the soletronate compound we have already with gallium and lutetium with actinium, and we see a similar profile. And maybe we can then add the alpha radiation profile to the good pharmacological profile of the bisphosphonates. And something I just learned after the European Nuclear Medicine Congress in Barcelona, a colleague told me, why do you always underline that with lutetium-177 you are really only addressing the bone metastasis by saving the red bone marrow? You can also argue the other way around, that for some patients it is better to use yttrium-90 instead of the weak lutetium-177, exactly in order to destroy the bone marrow behind the metastasis. So this is just a new suggestion I got 1 month ago, and before I left to Australia, I got a new journal from the Radiochimica Acta, and I saw exactly that there's a group in India. They do it already. They, at least in animal studies, they measure the uptake of yttrium-90 BP-AMD, and using organ distribution in healthy rat, they extrapolate to human the absorbed dose to bone surface, bone marrow, and total body. So this is just a vision, and just to make this story complete. But in conclusion, I would say we are really having now in our hands the most specific molecule for delivering a therapeutic radiation dose to bone metastasis. We have collected a significant number of clinical information which underlines this concept, and now we are going into more systematic patient applications. And whenever you are interested to join this group of collaborators, please feel free to contact us, and we will be happy to deliver the compounds. Thank you very much.